You are audible.
600 MIPHs. Either I can fire this way, right? Or I can fire this way, or I can fire this way. Are you able to see? So if I do it this way, my scapula is already winging. So the force applied is not enough, and there may be hesitancy. So in this position, I would prefer to apply it this way, right? Now, as doctor mentioned, we remove the lock, right? And we fire. And then we remove. And then गायत्री मंत्र, गणपति आरती और नमोकार मंत्र का और एक टाइम. So we wait for a while. And then, as Dr. Nitish mentioned, you rotate it 270 degrees. अब यहाँ पे प्रोट्रैक्टर लेके नाप तो नहीं रहे हम लोग 270 degrees, है ना? So more than half a turn. And then थोड़ा left, थोड़ा right, थोड़ा left, थोड़ा right. That means there is no impingement. That means the cut is perfectly done. And the stapler comes out. और बाद में अपशगुन माना जाता है अंदर देखने के लिए. पहले पैक करके रख देना. Okay. In the meanwhile, so we'll keep the 9 o'clock long and keep the 3 o'clock short. So we get an orientation. Okay. Mop देना please sister. Right. Now we see that we have a complete donut, right? But this is not enough. This is not enough. What I would do is stapler पकड़ो, आर्टरी पकड़ो, नहीं उसको पकड़ लो, हाँ, forceps दो, scissor दो, खींचो, 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 yeah. Cut.
Can we have?
Nikla? Now we can just remove this thing without cutting. Pujal. Done.
Okay.
Without cutting. So you have a nice donut. Now what I always say is, if you can play with the donut well, that means you have exercised enough. Otherwise there will be small bridges, there will be buttonholes, there will be thick area, and then that is not a complete.
Hello. We are shifting the audio and video to our 2OT1.
All right.
Yeah. Thank you.
Good afternoon, everybody.
Yeah. Can you show us a staple line?
Show the staple line.
Good.
Hello.
Same speculum. Jelly लगाओ.
Hello, Dr. Deepali.
Yes, sir. It's audible, sir, and visible as well.
Okay.
So, are you able to see the case? Is there?
Yes, sir. All the moderators are there,
Okay.
and the case is visible as well, sir.
Okay, so it is a rectovaginal fistula 2 months before patient had a delivery. I have passed a feeding tube through the opening, right? I think it is not very well seen, but most of the time. Are you able to see it? Yes.
Yes, sir.
Yes, same way there is a opening inside the rectum which is about 2 centimeter. What we normally, there are two methods to do it. One is we core it out and take a sutures, but it will not give good sphincter apposition. So what I do is I will first give us only saline. Normally we also give saline with adrenaline, but the patient had a history of convulsion, so I am not using adrenaline, using only saline. So it will create a good plane in between, and my basic principle is put a transverse incision at the junction and close in a vertical incision. That is the basic principle of this RVF.
Sir, what is the etiology of this fistula?
Post-delivery.
Post-delivery.
Mines is there.
Good afternoon, sir.
Good afternoon.
Me, Amrish and Nikunj are there. Here, sir.
So you have become moderator from chairman?
Yes.
So all moderators have gone.
Thanks to Pritesh Patel.
So you can stop whenever the oration and everything starts. I don't mind at all. You can tell to the Pritesh also. This is the case we are doing because we have taken this case and we want to finish them off. That is the basic right.
No, sir. We are also interested to see this type of cases, sir.
दबाए रखना.
So what are you injecting? Only saline or with
that I said,
adrenaline?
adrenaline is better, but in this patient, I don't want to use because the patient has a history of convulsion. The patient had become fit only today morning. Otherwise, might have taken this and wait. Usually, we wait for a few minutes. When we give adrenaline, here there is no need to wait. So the basic principle is knife 15 number. I use the plastic knife. Put a transverse incision extending over towards the side of vagina. Exactly at the junction of this, what we call U shape or double S shape incision, more towards vaginal side, so the sphincter can be preserved. Just a minute, I will take it, right? Sometimes if you need, you can extend it on this side also, make it double S type, but this is what we like, slightly U. Tooth forceps. કોટરી કેટલા પર છે બીજો ટૂથ આપો ઓકે ઉપર પકડો લાઇટ સેજ. Are you able to see it?
Yes, sir. Yes, sir.
So once you go beyond fibrosis, there is a potential space which will be open easily. Either you can use sharp dissection or even artery forceps. So you can judge it. This is a vaginal. હજુ patient ને થોડું straight કરો ને, easily આ લોકોને દેખાય. So this is what I am doing. So I am entering. This is the potential space where the saline was given. You can see that is entered. My artery has gone in.
Yes, sir.
Same will repeat on opposite side. This bleeding is because of the non-using of adrenaline, which did not keep it very bloodless, but it is necessary. So you can see that on either side I have gone.
તમારો હાથ વચ્ચે આવે છે
Haji.
એટલે વિડિયો વાળાને કે થોડું ઉપર લઈ લે.
So now you can see thing, I think, right?
Yes, sir.
So on either side you can see that I have entered. This is the potential place which will be helpful. Now I will cut it vertically on the vaginal wall up to the fistula and may remove the extra part. Let us see.
Sir, please ask the cameraman to change the
Position.
angle because your
Yeah.
hand keeps on coming in
But
between.
this is the point, yes, he will have to change it. I have straightened the patient also for that reason also. Let us put, will it help or not, I don't know. Okay, now I think you are able to see it. Alice apo, chalo, let us see.
કેમેરા વાળાની મૂવમેન્ટ બહુ વધારે છે.
Now I think you are able to see it.
Now we can see.
This is the opening.
Cameraman is shaking too much.
That is not stabilized.
Okay, let us go to plan B. No issue. Are you able to see anything?
We can see, sir.
Clean करो. I'm sorry for that. Suction एक add कर दो न तो clean થાય ને તો. Okay. So this is the area of fistula I have reached. I will remove the fistula and mass. लाओ पकड़ो फॉरसेप मैंने आपको सक्शन लगाई दो. This is the fistula between આ રાખજો બાયોપ્સી માટે. ચલો. Now as you can see they are practically fused here. The vagina and the rectum. So that will have laterally the space is made. But on this side, suppose this is the vaginal wall, this is the rectal wall. I don't know whether
What
you are.
about the sphincter, sir?
We'll show it. Still, we are not reached there. We'll have to separate this portion. So even beyond the fistula, they are fused. So if you don't separate them right up to the levator ani, the chances of recurrence is very high. You can see this is rectal mucosa, this is the sphincter, and this is the vaginal wall. Now this is the space I have created right up to there on this side. મને એક ગોસ પીસ આપી દો. પલાડીને સલાઈનમાં પલાડી અને આર્ટરી પર. થોડો મોટો આપજો તો રહી જશે અંદર. Okay, so this side I will repeat the same thing on opposite side. This is the external one. You can see that that is practically they are fused like anything. રાખો.
Mr. Chairperson, please ask the cameraman to focus it properly because we are not.
Sir,
Yes, sir.
Modi sir,
Yes.
can you ask the cameraman to focus it
I will go
properly?
little on opposite side. Let us see. Just let me complete little bit of that. I will give him a lot of space also. Now this we have reaching the levator ani. This is on this side. We have made a space right up to the ischiorectal on either side. So there is they are still fused in midline. I don't know whether you will be able to see it or not. Yes. Bijo Alice apo.
So not properly seen, sir.
Yes, just a minute. Yes. Bejuda. Amuki de. Now you can see that this is the rectum. I think able to
Yes.
appreciate it.
Yes, yes.
Right? So this was the vaginal wall of one side. This is the opposite side. I have removed the fistula, but you can see still this rectum and vaginal wall are fused. I will have to separate it right up to levator ani and then bring these muscles which are perineal muscles in midline. And the principle is that I close the vaginal wall, I close the rectum and bring the muscle in between. So it will be 3-layer closure. That will help
Okay.
the patient prevent the recurrence. આપણે બાયપોલર છે ખરી લીધેલી જ છે ને ક્યાં છે લાવો બાયપોલર આપી દો પગમાં છે કયું ફર્સ્ટ કે સેકન્ડ યલો કે બ્લુ શ્યોર ઓકે નોટ વર્કિંગ એઝ યુઝ્યુઅલ ચલો કંઈ વાંધો નહીં હા એટલે બરાબર યુ કેન સી this vaginal wall. I will have to separate it from this side. If you have to air on the side of vagina, because any opening over the rectum higher up is disaster. Now I have reached right up to upper part. So this is the external sphincter which we have intentionally cut. You can see this. This is the internal sphincter and we will bring this sphincter together on either. This is the levator ani. Can you see it on this side?
Yes.
I don't know whether you are able to see or not. I am not sure about cameraman. Opposite side also.
Can someone retract on this opposite side, sir?
Yes. Can you see it both side?
Yes, sir.
So this is the principle. We will bring this together, close the vagina here and close the rectum here. First I will close the rectum, keeping the knot inside the rectum. Over that I will close the sphincter, levator anal and vaginal wall. Already refashioning is done. PDS 20. लाओ वाइक्रिल 20 आप पीडीएस ना हो तो वाइक्रिल આપી દો એ કયું શું છે 30 will be 2 લાઓ 30 no problem normally I use either Vicryl 10 or PDS 20 depends upon that. This is, you can see that the sphincter is slightly not completely cut. લાઓ એ બી લઈશું.
Yes, sir.
So this is the highest point where we have done a dissection. Forceps બીજો આપો. So not inside.
Sir, you are taking with the sphincter only or only?
Part of that is the rectal mucosa. Will have an internal sphincter is a part of the rectum.
Okay, sir, you are taking with it.
You can see apex of where up to we have done dissection. I will keep this long for you to see it. ફોર્સેપ આપો ને બીજો વાર નથી પકડો પછી લો. I would see there is no opening beyond it. આ એક પકડી લો, આ કાપી નાખો. મોસ્કીટો આપો, મોટું મોટું, બહુ નાનું. યસ, ક્લીન કરતે हैं. I think you are able to appreciate this. Beyond that is normal rectum, forceps. પછી Vicryl 1 number 1 જોઈશે આપણે. This is just for, I don't keep it too much of that. But as you can see this is the suture. Needle holder પકડતું નથી because it is 30. બોથ. બીજો એક મોપ આપી દો ને. All three simultaneously, don't take it one by one, take simultaneously. Few sutures here, few sutures. This is the external sphincter which I will take separately. We have almost reached outside.
Sir, are you keeping the threads somewhat larger?
No. This was the only stay. This is, I am suturing not inside. Okay. Standard suturing with not inside. At the end of the this transverse will become vertical. That's the point.
Okay.
Now as we have come out, I will release this portion.
Sir, will you keep any drain post-operative?
No drain.
Okay.
Only vaginal pack. So this is the part of the anus part we have taken care.
Yes, sir.
Cut it. Vicryl 20 આપી દો મને. So we'll take. So this is the lower part. You can see that I have partially, but this is only wall. So if you keep it like that, so we'll have to bring the muscle in between. Can you see this? This is
yes.
Rectal wall.
Yes, sir.
Now I will take the partially suturing the vagina. Here the again not outside. That means away from vagina. In
Okay,
that we, because we want a mucosa to evert, so that why not in rectum is always towards the rectum. Here it is away from. આને પુલ કર ભાઈ, એ મારી બાજુ નહીં, તારે નહીં, મારે લેવાના સ્ટાક, તારી બાજુ ખેંચ, આમ, યસ, વેરી ગુડ. આ પકડો. નીડલ હોલ્ડર નથી સારું, આપો ને બીજું. Okay, let us see. મોટું મોટું ભાઈ, આમાં નાનું કાપવાની કોઈ જરૂર નથી. ના કટ નહીં, બહુ સરસ. થોડી કંઈક સારી આ બધું છેલ્લા ઓપરેશનનું છે. You can also take Vicryl 10, but then you should have a smaller needle of Vicryl 10 that will pass inside. Our large needle may not pass, so that is usually causing the problem. So that's why I am taking 20. Sadi
Sir,
scissor.
PDS is not better than Vicryl?
Yes, but I like this not putting on vaginal side.
Okay, sir.
You are lefty? You are lefty?
Scissor is not working.
Government just all the instruments.
પેલો Vicryl 1 તૈયાર આપી દો એ હવે મને. So this is partial closure I have done vagina, will not close because the sphincter I need to see. Alice કાઢી નાખ ભાઈ.
Yes, sir.
આ પકડી લે એલિસ કે નથી.
Excuse me, sir. Jigar here.
હમ
Hello, sir.
હા બોલ ભાઈ.
Would you like to put a barrier like F-gel in between the space?
No barrier, I will put a sphincter as a barrier.
Sphincter.
Copy.
F-gel may cause means hemostatic purpose also.
No, let us complete then only.
Okay, sir.
Let me complete then question of hemostasis and the gel form has no role actually. લાવો 1 નંબર આપી દો. તમે કહો સારી એટલે કાપે એ સારી કહેવાય, તમે બોલો એ સારી થોડી કહેવાય, જે કાપે એ સારી કહેવાય. ચલો ઓકે, લો આ પકડો. Look here, this is the what you were talking about. You can see this sphincter. Can you see it? I think you are able to appreciate it.
Yes, sir, we can see it.
That is a sphincter that will now act as a barrier.
So this is a levator, no?
Levator. ટિશ્યુ કટિંગ કાપતી હોય તો એ આપો ને અત્યારે. ભાઈ આ 2 વાગ્યાના પ્રોબ્લેમ છે બધા. આ જુઓ તમને, મને હું કદાચ ભૂલી ગયો કઈ રીતે કાપવું એ. લો તમને આવડતું નથી, સિસ્ટરનું એમ કહેવું છે. I think I am able to, are you able to appreciate now what I am doing?
Yes, sir, we are seeing it.
No, can you see the levator?
Yes. Second suture of levator.
Levator. So that will keep it separate and this will be together. અમારે અહીંયા એક પ્રોબ્લેમ ટેકનિકલ થયો છે. 6 સીઝર વાપરી, એકે ચાલતી નથી, એટલે એનું ડિસ્કશન ચાલી રહ્યું છે. ડોન્ટ
Sir,
વરી.
they have
એટલે ભાઈ એ રહેવાનું, એ
they have
રહેવાનું.
the stalls here. They can bring the scissor. new
અલે ભાઈ
scissor.
સરકારને આ ચાલી ભાઈ, વેરી ગુડ સીઝર.
Exhibitor can provide the scissor, sir.
Not scissor, and I am a person who use only basic things. Now I will cut this scissor apo, which is rectus. I think now it is getting separated, as you can see. Yes. લો રાખો. હવે look, this is the another sphincter. Can you see it? Part of it.
Yes, sir.
You will bring it together. There will be enough space between these two, so chances of recurrence is there. One or two sutures may give way, but doesn't matter. Cut. પાછું તારા હાથમાં નથી ચાલતી લે તું ના વાપરીશ મને જ આપ. This is the external sphincter I am going to suture now. દેખાય cut end of external sphincter.
Yes, sir. We can see.
Okay?
Yes.
મને જ આપો એટલે ગાળો પડે તો મને જ પડે કોઈ વાંધો નહીં. લે કાપ્યું સરસ. Now again the second layer. હા હા પણ કાપવાનું નથી ક્યાં કાપવું તો ભાઈ વારો આવે ત્યારે કાપું ને અત્યારે જ કાપી નાખું કંઈક. This is because of slight still there is edema is there, only 2 months has passed.
So normally, sir, for how long we have to wait?
Better 3.5 to 4 months. Sometimes 6 months is even better.
Minimum 3 months.
Ideally.
Okay.
Cut. Now I will, you can say I have not trimmed a vaginal wall because I would like to see it should not become very bad. You can see this is the part. Now I will cut the little bit of vaginal wall, make it straight. Scissor apo mana, patli. Because this is not a good tissue, but I have kept it for a last. Can you see it? This is extra or rather inflamed one. I am cutting it.
Maybe a part of fistula, sir?
Not a bad, but vaginal wall it is.
This
તમે મને
seems
આપતા
to be
તે scissor છે?
fibrous tissue.
આ સીઝર બીજી પાછી બદલી કાઢી તમે? Just to prevent the tension. લાવો Vicryl 20 આપો. આટલી વાર બે ટાંકો લેવાઈ જાય મારે. તમે બે જુદા જુદા નીડલ પર તૈયાર કરીને રાખો, ઇઝી પડે. શોધવું પડે એવું થોડું ચાલે. ઓકે.
So now, sir, you have started vaginal wall?
Yes, again, because partial closure I will do vaginal, that go on. That's why I say not a complete one. This is the anterior vaginal, posterior vaginal wall which I am suturing. પેલો suture કાપી નાખ બેટા. આ બી કાપી નાખ. We have come out, no problem. ભાઈ તું પેલી બાજુ કાપી નાખ. ના ના શું. નાઈફ આપો ચાલો. Give me knife. લો.
Sir, I think this instrument problem is universal,
Worldwide.
worldwide.
Worldwide. This is also type of you can call partial vaginoplasty.
Yes, now it's working. Sir,
બોલ ભાઈ.
we are running the short of time.
Okay, you can go
We
ahead.
are now going for oration lecture, sir.
You can see that I have almost completed vaginal wall in
Yes,
pivot.
sir. Yes, sir. Yes.
It
We
has
can
become
appreciate
completed. What I will do is take a few suture in between.
Yeah,
At the,
it's a wonderful demonstration, sir. Thank you very much.
okay, thank you.
Thank you very much.
કાઢ લો. લાવો 1 નંબર વાયકરી લાવો. જોયું ને આ રાખાય પહેલેથી જ કરાય. હા આ તો બધા બચી ગયા પેલું ચાલુ છે એટલે બંધ થઈ ગયું. બસ હવે આવી જાઓ તમે. હવે કાન બંધ કરે વાંધો નહીં. યુ કેન સી જો આપણા વાળા માટે આ તો સ્ફિંક્ટર દેખાય છે. આપણે ક્લોઝ કરી રહ્યા છીએ. સ્ટેપ 1. જો મારે વાર થાય ને તો હું મારા
Thank
ધીરે
you so
વાત
much, sir, for moderating this session.
એટલે હજુ ચાલુ છે આ તો ચાલો.
I would like to call upon the stage Dr. Pradeep Sharma, Professor and Consultant at Jahangir Hospital and Research Center.